Now we've come to the nightmare. Here's your patient. A 45-year-old male with shortness of breath. Past medical history, CHF, OSA on home oxygen. He's been using nebulizers all morning with no improvement. He appears significantly fatigued. Respiratory rate of 28 and using his accessory muscles to breathe. His oxygen saturation is 80%. And he looks like he may need to be intubated. First thing you need to do. We talked about CABCs before. Well, this is PABC. Pray first and then go about the ABCs. I used to say you should approach every airway as a cricothyrotomy. If you know you can cric them, the intubation is easy. But I would argue in this case, that's a nope. What you really want to do is avoid intubation. Maximize oxygenation and ventilation. Supplemental oxygen is key. Also, BiPAP. Make sure he's sitting bolt upright. Give him inline bronchodilators through BiPAP. And definitely do the serial VBGs. You're going to need to know what's going on with this guy so you can predict if and when you absolutely need to intubate him. And you got to decide what your priorities are because, as you know, oxygen failure leads to ventilatory failure and ultimately cardiac arrest. And this guy is well on his way. It's like a race car. From the time someone who looks like this can't breathe to when they die is very quickly. So you have no time to lose. Relaxation is the enemy. If you make this guy relax, his soft tissues and his oral airway will be obstructive. The weight of his neck will cause tracheal collapse. The chest wall's got to weigh 50 pounds laying directly on the anterior chest wall. Imagine if you had 50 pounds laying on your chest when you were short of breath. More than that, you've got no diaphragmatic excursion because he's got a 100-pound abdominal ball. How much positive pressure do you think it would take to move 150 pounds of chest and abdominal wall? Too much. Do you believe you can bag past his collapsed soft tissues and his oral cavity? This is all just nightmare stuff. Here's your best friend for this guy. Especially if he's got a little CO2 retention and he's a little confused. Get that nasal airway in. Get past at least the oral tissues. And definitely make a prompt decision. Wait, decision? What are your choices? Lying him down and intubating him? That's a hard no. Unless you think you can get it done remarkably fast. Yeah, no, pipe dream. That's still probably a no. He's going to have oxygenation failure, ventilatory failure, and he's going to move on to cardiac arrest so quickly. If you lay him back, you gotta be a lotto winner to get that airway fast enough for this guy to do well. Perhaps you should think about doing his airway while he's still upright. While this may be technically difficult, we can consider the options. LMA is the go-to in someone of this size, or at least the backup. You should use your laryngoscope to assist in placement. Here's a few options. Fiber optics. If you've done this before and used them, this is a good way to approach this airway. Definitely the fiber optic airway should be in the hands of someone who's done it the most, especially in someone of this size who's such an enormous challenge. Make sure you keep the oxygen on during the procedure. If you're going through the nose, keep the oxygen on the mouth. If you're going through the mouth, keep the oxygen on the nose. LMA in the second picture. You can put the LMA in, and you can actually use the laryngoscope in this tomahawk position, which is seen in the next picture, to facilitate the placement of the LMA. This is the tomahawk intubation. What you do is you turn the laryngoscope upside down and change the camera and intubate them while sitting up. It's really very hard to get behind them and try to intubate them while they're straight bolt upright. This is a little bit easier. Remember, you might need a step because when you're doing this kind of airway, it's better to be a little bit higher than your patient. So whenever you tomahawk the laryngoscope, use a step and put their bed all the way down. Do you think they're going to tolerate this tomahawk intubation? Maybe. Maybe not. So you got to contemplate your RSI. Ketamine is probably a good idea. So you don't collapse the airway completely and cause a problem for yourself. The patient will still suck air and perhaps be in a world of their own so that they don't care that you're trying to tomahawk their airway. If they start to freak out with the ketamine you give them, just push more. What about paralysis? You better think this one through. Generally, this is going to be a no. If you can't get it any other way and they're fighting, should you give paralytics? Perhaps, but just realize as soon as you paralyze them, all that weight is going to collapse down on their airway. So it better be worth it. You get it in! Outstanding work. Post-intubation, don't forget that the patient should remain upright. That ventilator can't work against that body weight. Sit them up so you can decrease the positive pressure needed to ventilate the patient. This guy shows up. Shake his hand and then check his landmarks. Hello, sir, I'm your doctor. May I feel your cricothyroid membrane? When someone has angioedema, if it's static and they're not getting worse, this may not be that big of a deal. If they can phonate the letter I, as we talked about before, I clearly says that the cords themselves are not currently affected. As soon as you start to get the muffled I, you got to worry that the swelling is near the cords. Even the letter E suggests the soft palate is involved. And with angioedema, that can be a very big deal. Progression is a terrible sign. If it's getting worse quickly, you're probably going to have to move before you don't have a choice. What are your options? Again, the nasal trumpet is your friend. You can consider video laryngoscopy. If ENT is there, if you're really good at it, this is certainly a consideration. Remember, though, that if you aggravate the airway and don't intubate them, you can cause a problem that you have to solve with cricothyrotomy. Just don't wait until it's too late. When you're thinking about a cric, there's several steps. We can think of them in the ready, set, go pattern. The things you can do when you're thinking that someone might need a cric, but possibly not, is go ahead and get ready. Start the process so if it happens, there's very little you have to do. You can identify the landmarks and mark them. Yes, you can mark them with a Sharpie. Someone who could lose their airway and die, I'm sure will be okay with a black line on their neck. Betadine prep. If you paint the neck and you don't need to cric them, well, wash it off. Don't worry about it. I would even go so far as prepping with the lidocaine with epi so that you can decrease the bleeding when the time comes and you need to actually do the cric. If you had to inject with lidocaine with epi in someone with a severe swelling of their tongue or some obstructive problem like this that was going to intubation and was going to be a difficult airway, would it be wrong if you injected lidocaine with epi in their neck and then never actually cut it? Please, if it's me in this situation, get yourself ready in any way you can so that if the time comes, you're ready to go. The next step is the skin incision. The skin incision is not a cric. It's just a skin incision. Preparation is not a commitment. If you do happen to cut the skin, feel the actual membrane, see how deep it is. Get some understanding of what you're going to have to do before you go. Again, cutting the skin and feeling the airway is not a commitment. You can always sew it up later. But if it's go time, then you make the cric incision and intubate with a bougie. When you intubate with the bougie, you should feel the rings. If you don't feel the rings, try to bury the bougie. If you hit an obstruction, that's the carina. You're in the right place. If the bougie just goes and goes and goes with no obstruction whatsoever, you should be concerned that you went through to the esophagus. This particular point is much more important when you're doing an oral intubation and you're not sure if you're in the trachea or in the esophagus. Scalpel, finger. That's the trick, right? Cut the skin, feel the membrane. Cut the membrane, feel the hole. Fast cricothyrotomy. That line on that picture suggests that you need to cut the hole like a thoracotomy scar. That is relatively large for an incision for this particular process. I did not make this slide, or I would have made that line a bit smaller. Feel the rings, bury the bougie. That's all you need. The blade, the bougie, and the tube. Usually it's a 5.5 tube, and then you got to cut it down to size. This is important. Just don't wait until it's too late to do the cric. In the aftermath, you're before the judge, and the judge says, so, let me get this right. You're trained to do a cricothyrotomy. In this patient, predictably, that would have been a relatively easy and life-saving procedure. But instead, you tried to intubate him, did you say 6 times? After the first 5 times didn't work, what really made you think that 6th time was going to be the trick? And finally, when the patient arrested, then and only then did you initiate this life-saving procedure. Is that correct, doctor? This happens all the time. People try to intubate when they have a perfectly good neck to access the airway. Don't wait until it's too late. Remember, you have this skill. It's not that big of a deal. If you can't get the airway in any other way, don't continue, don't persist, don't keep trying different ways. Cric the patient, save the life. Once they're cric'd, sometimes you get a big air column that comes up toward the cords. Once you've secured the cricothyrotomy, sometimes it's simple to intubate. So then just go ahead and intubate them after the fact, sew up their neck. Not a big deal. Much better to explain why there's a scar on their neck than why they're dead. All right. As you go through these things, you get closer and closer to being ready to dealing with these things on your own. Feel ready? Nope. No rest for the wicked. Now